Welcome back. Thanks for joining me on this discussion of benign liver masses in the section of general surgery. Today we'll talk about two of the more common presentations of benign tumors, a hepatic adenoma and a hemangioma. Hepatic adenomas are commonly associated with birth control use and may have a tendency to rupture and bleed. In distinction, hemangioma is the most common tumor of the liver, benign tumor that is, and generally speaking, it's found in young to middle-aged women. As a surgeon, when I'm in the patient's abdomen, I commonly see asymptomatic hemangiomas when I look at the liver. It's usually of no clinical consequence, and it's a vascular malformation. Physical findings may include right upper quadrant abdominal pain, but the vast majority of patients with both adenomas and hemangiomas are asymptomatic. You may get some routine labs, and the chemistry may be absolutely normal. And in fact, the CBC is likely to be normal unless the patient is actively bleeding, and this may result in a decrease in the hematocrit. Liver function tests are usually not very helpful for hemangiomas or adenomas. This is a cross-sectional CAT scan of the abdomen pelvis. It demonstrates a centrally located hepatic adenoma. This looks a little bit different than the previous CAT scans and is again a cross-sectional CAT scan of the abdomen pelvis demonstrating a hemangioma with particular or specific vascular filling or at different contrast phases.
Hemangiomas are largely observed. You wouldn't do a biopsy as there is increased risk of bleeding. Rarely there is a surgery necessary. Of course, if it's enlarging rapidly, causing pain and bleeding similarly to the adenoma, we would offer surgery.
Medical management of hepatic adenomas include stopping oral contraceptives, if feasible, and sometimes need to be operated on if they're enlarging rapidly, causing pain, or potentially bleeding. Hemangiomas are largely observed. Rarely a surgery is necessary, of course, if it's enlarging rapidly, causing pain and bleeding similarly to the adenoma, we would offer surgery. Let me pose a question to you. How do you differentiate between a focal nodular hyperplasia versus an adenoma? I'll give you a second to think about this. The answer is a sulfur colloid scan. A sulfur colloid scan involves using a technetium-99m scan, and the colloid, which is tagged, is preferentially taken up by the Kupffer cells of the liver. Let's take a look at the differences between an adenoma and a focal nodular hyperplasia. For adenomas, they're generally associated with right upper quadrant abdominal pain, and on the sulfur colloid scan, they don't have any uptake of the dye because they lack Kupffer cells. They may be considered precancerous and is associated with oral contraceptives. Contrastly, for focal nodular hyperplasia, these lesions are usually asymptomatic. They do uptake the sulfur colloid, are not precancerous, and not associated with oral contraceptives.